Okay, so welcome today to Mr. Malcolm's podcast. I have with us Dr. Matthew Budoff, professor of medicine at UCLA, and you're at the Lundquist Institute as well, eh?
Yes.
I want to talk about a few things. So there's the little bit of the keto CTA stuff, but we'll get to that. I want to touch on testosterone, a little bit about that stuff, and the new guidelines that just came out. So to start off, you've been doing calcium scans and stuff for your whole career, and cardiovascular disease is still the number one cause of death. And we have statins like Lipitor, Crestor, we have PCSK9 inhibitors, we have a lot of things. Why do you think it's going up still?
Oh, sorry. Sorry about that, Aaron.
That's okay.
Why is calcium score utilization going up or?
No, why is like overall heart disease and
Oh,
cardiovascular disease going up?
yeah, that's a great question. I don't think we have a great answer. I mean, obviously the population is aging, so some of that will just be an aging population. More people are living to older age, and some of that will come with heart disease. But it's really somewhat unexplainable. In the last 15 years, since 2010, we've seen an uptick in cardiovascular death after a 40-year decline. I think maybe some of it is saturation of statins. We get as good as we're going to get with the statins, so we lost that benefit, and then saturation with blood pressure control, which was the call of the earlier generation. And now maybe just aging is just and obesity maybe which is going rampant, is just leading us down this road of more metabolic syndrome and more cardiometabolic disease.
Right, that makes sense. To get into like the guidelines now, so I got into, quite a debate on social media about calcium scanning. There's still some less is more people that say there's no evidence. It just goes back and forth. They say the same thing. To me, it's kind of a common sense thing too. If you have a high calcium score, you have plaque, and that means you have the disease. So treating it differently than someone who doesn't have disease to me is just why do you have to have a randomized controlled trial to prove that?
Yeah, and I would suggest that to get a class 1B recommendation does not require a level of evidence B is not a randomized trial. So the indication is appropriate and the guideline recommendation is appropriate because it's proof of athero. There's literally thousands of studies published of coronary calcium. I've published hundreds of papers on coronary calcium and large observational studies from every cohort study you can name. And they always show the higher the calcium score, the more patients have cardiovascular events. So if we know that you can take those patients who have high calcium scores and lower their risk with a statin, which was proven in
Right,
the Saint Francis Heart study, that you take people with high calcium score and you put them on a statin and they have less events, then we have enough evidence to say that it's a risk marker, and the higher your risk, the more we want to treat. It's got more evidence than the prevent risk calculator that got a class 1A recommendation somehow. So you can't, if you're going to rail against anything, rail against the prevent risk calculator, right? I mean, if less is more, why would you sit idly by and say, "Oh, the risk calculator's great. It hasn't been validated in any study. It hasn't been used in any randomized trial, but it's a class 1A recommendation to do it." That's what you should
right,
be railing against. If they want to do less is more, they shouldn't be calculating their prevent, they shouldn't be using the prevent risk calculator.
right. Yeah, that makes sense to me and a lot of other people. But yeah, the same thing. You get a calcium score, and they say it leads to downstream testing and stuff like that. But like any test, I think you use it appropriately. Any test can be used inappropriately.
Right.
You,
That's a
you,
great point. It's so true. I mean, it's just any test can be abused. And I
right,
don't think we don't have good evidence that there's a lot of abuse with calcium scoring. Well, people always point to anecdotes. There's a million anecdotes about anything. The evidence is in the MESA trial, which was 25 years ago, we did calcium scores before people fully understood them. And when there was more potential for abuse, there was no increase at all in invasive angiography or stents after calcium scoring when you compare it to a similar cohort that had no calcium scoring done at that same era. So we know that it doesn't. I published that paper. We know that it doesn't lead to excess in as a whole. It doesn't lead to an overall excess of invasive angiography and stenting. Obviously, there'll be some individuals that went down that route, but in general, we don't have good evidence that it has been abused or that it is currently being abused. And that's on us as the people who advocate for calcium scoring. We have to educate the doctors and the patients that get them on what the appropriate next steps are. And the appropriate next steps are statins and aspirin and blood pressure control and weight loss and smoking cessation, not cardiac cath and stent and bypass surgery.
right. Yeah, so like I said, it's used appropriately. I think it's a really good test. And you had mentioned statins, so I still get into it with people about statins. They melt your brain, they're going to make your muscles fall apart. My dad's been on a statin for like 30 years. He's completely fine and healthy. So talk a little bit about that, just statins in general. What
Yeah,
are the true side effects? What are the myths?
so we've looked a lot at statins and Alzheimer's disease and global dementia and amnesia, and there is a very rare uh, conditions where some people get foggy brains, but it's definitely in large trials where we've studied this extensively with really good mental status exams. It's probably less than 1%. So I would argue that 95% or more of cardiologists are on a statin. So if we think 95% of them are all dim and not thinking clearly, then that's a whole different argument. But I think there's great evidence that it saves lives. We
Right.
have wonderful evidence that you live longer on a statin when it's used appropriately. And there are some small side effects. The muscle effects are probably around 5%. I know more people complain of muscle problems, but I think that's Dr. Google and nurse practitioner Siri giving out bad advice sometimes to patients.
Yeah, I know a lot of people that have stopped the statin and they still had the muscle pain because maybe they had the flu or like so many things cause muscle pain. You can't just always blame the statin.
Exactly.
So now I just want to discuss a little bit about the testosterone. Now there's, everywhere there's low T, things are popping up. It's all over social media. Everybody's got low T. Um, so I want to talk about the Traverse study, or as your editorial said, that travesty. Why was it a travesty and not a good outcome study?
Well, so yeah, so I mean, they planned on enrolling more patients than they actually enrolled. So that the study design was powered to have 6,000 patients. They never got close to that. The minimum follow-up was supposed to be, I think it was supposed to be 3 years. They never got close to that. The the on treatment, the patients who stayed on treatment were 38%, 62% stopped therapy. So when you have an intention to treat and they're not on the drug, yes, they can't get any safety problems from testosterone because they're not taking it, but they're included in the on treatment arm. So we have no data on per protocol what happened to those patients. Maybe all the patients taking testosterone were the ones that had the heart attacks. Like so we had insufficient follow-up, insufficient treatment. The average levels that they achieved were like 400 testosterone levels. So very low compared to what people are doing in the real world. So I don't take the testosterone study as proof that I can replete men to a testosterone level of 800 or 1,000 safely because we don't have that data from the Traverse trial. It failed on so many levels that I mean I couldn't believe that the FDA literally accepted that as proof of safety because the dropout rate was so high, the follow-up was insufficient, and the enrollment was not to target based on the power analysis. So like they missed on every endpoint and then they concluded that it's safe. And I think at low levels, it probably is safe, but that's not what men do. Men want to be 20 again. So you have these 70-year-old men that want to have testosterone levels of 1,000 so that they can pump iron and have less impotency and all of that. But like it's not what the study was designed to do, or certainly not what the study achieved as far as safety.
Right. And I should have mentioned before you did a few imaging studies, right, which showed that testosterone actually increased plaque.
Yeah, I mean, I
volume.
published that in JAMA. So in JAMA 2017, we did a prospective randomized placebo-controlled multi-center trial, as good as you can get, looking at serial CT angio, and those patients on testosterone had more plaque development across every plaque measure. So they ended up with more heart disease or more atherosclerosis at the end of a year than those on placebo. And the hypothesis was the opposite. So it's really hard when you design a trial to show the opposite, which means it really is correct. And then the people who did the math were endocrinologists who believed in testosterone, didn't believe the data that they did on their own because I just read the studies blindly. They made me reread the studies and then do a reproducibility study that's published in the supplement to show that this was highly accurate and that this was the real result. So we had to conclude that testosterone caused